Thank you so much, Katie. And it's a pleasure and an honor to be here. My topic today is is keeping out of the emergency department, which I think is important in two ways. One, I don't want you to be so out of control that you need to go to the emergency department. And second of all, it's really an awful place, at least in Philadelphia, if you have a bad migraine. If you go to Jefferson, 50% chance you'll be stuck out in a hall that's loud and bright and people bumping into you. And it's just awful. What an awful environment for people with migraine. And we can do better. And here are some ideas. Now, I'm a physician. This is about treatment. I can't say what's right for you unless you're my patient, but I do think that these principles are valid, and it's good for patients to understand them. I am a speaker and am involved with multiple companies that have migraine products. Perhaps the most relevant one is that I'm a medical co-director of Control-M Health, which is an app that helps people with behavioral treatments for migraine, such as exercise, relaxation, biofeedback, movement, et cetera, sleep management, et cetera. Kind of in line for that, when you think about your treatment, you should think about what you're doing in 4 different areas, I think. Or as I like to put it, what's in your boxes. There's abortive treatment where you take something and you try to stop the attack right there and then. There's preventive treatment that builds up over time and eventually helps to control the frequency and severity of migraine attacks and reduce the disability of migraine over a time frame of usually months. And there are things that you can do with your mind that are healthy and beneficial if you have migraine disease. And one must not forget to take care of the body with really some very simple things can sometimes be very helpful, from sleep to stretching to gentle exercise, if you can do that. Now, what are the general principles of treatment? Recognize triggers and mitigate them. I do want to say that I think there's something of a tendency to over search for triggers for some people, and that may not be a good idea. But if they're out there and they're easy to identify, absolutely. Treat early. And for almost every medicine, there's a real penalty if you wait for treatment. And remember, for many people, you've got to go around the stomach. Obviously, if you have a vomiting migraine and you're taking pills, there's a problem with that. It's not going to do what it's supposed to do. But for many people with migraine, for many of us, the stomach just slows down and you take a pill and it kind of sits there and it dissolves very slowly and it's absorbed very slowly. So the penalty for having a bad migraine is your migraine medicine works less well because it's just wasting your time sitting in your stomach, not doing what it's supposed to be doing. Use treatments, non-pharmacologic treatment. And maybe that's all people need, going to bed and having a good night's sleep and waking up migraine free. If you can do that and not using meds is absolutely fine. Quiet rest, cold compresses, relaxation, biofeedback. For about 60% of people, who have severe light sensitivity, green light can be quite helpful. And meditation. Use, but don't overuse acute medicines, and have a plan, a first line, a backup, and for some, a rescue treatment. So what are the acute medicines for a migraine attack? There are non-specific medicines, and they include, aspirin and Motrin and things like that. Those are the NSAIDs, and combinations, usually containing caffeine, and we think of Excedrin. Nausea medicines are actually very effective for some people with migraine. Those include compazine and Phenergan, or promethazine and chlorpromazine. Even, potent old-fashioned antipsychotics are like haloperidol and Thorazine or chlorpromazine can be extraordinarily effective to treat a migraine attack. For some people, a migraine attack can be treated with a corticosteroid like prednisone or Decadron. And those are very helpful. They don't work really quickly, so they don't help within a couple of hours. But there's a good chance that the next day is better after you start and get a dose or two of corticosteroids. And it does reduce the need for treatment days after the migraine attack. And opioids, can be useful rarely, but they're very fraught with overuse, rebound, risks of addiction, and just being further stigmatized for needing them. So there's something that's you really don't want to have on your list if you can possibly avoid it. And then there are medicines that are specific, and they work only for migraine and not for other kinds of pain, and really not for other kinds of disorders. And those include DHE, and some people still get the old-fashioned ergotamine. They're the triptans. There's 7 triptans. You might know sumatriptan or Imitrex, but there's 6 others, and they're perfectly good medicines. There's a new class of abortive medicines called the GPANs, and those block the CGRP receptor, and CGRP is one of the main pain molecules in the head, and controlling that is how the monoclonal antibodies like Vyepti and Aimovig and Emgality and Ajovy work. But they're also available as pill abortives, and those are known as Rimegepant or Nurtec, and Ubrogepant or Ubrelvy. And then there's one ditan available, and they're a little bit similar to the triptans and how they work, but but this one is quite new, lasmiditan, and it's a pretty effective treatment for a migraine attack, although it can have some dizziness as a side effect. So that's kind of the menu for treating a migraine attack, sort of your step 1 or your step 2 in your treatment plan. But you might need a backup. So if an initial therapy that hopefully usually works fails, it's good to have a backup. And sometimes you need a backup to the backup or a rescue therapy. Now, I want to make a little aside. There's a problem in headache medicine we've asked the American Headache Society to address, and they haven't, which is, what do you mean by rescue treatment? And that's really ambiguous. For some people, it's the initial treatment is a rescue because, they had a migraine and they want to be rescued for the migraine. For some, it's rescuing is at the point where the first treatment didn't work. And for some, rescuing is what occurs when the first treatment and the backup didn't work, and then you really need a rescue. So just be aware that while a lot of people use the word rescue, and it's a perfectly good word, it means different things to different people, and you might cause a little bit of confusion with that word. And I don't know what the right answer is. And I just think that, patients and the doctors should get together and decide on one word, the one meaning for that. And we'll all mean the same thing after that. But anyway, that was a little bit of an aside, and I do apologize for, going off on a tangent here. So here's one way that I like to think about sort of if you need to ramp up the treatment of your migraine attack. And everything in these columns is things that we use all the time to treat migraine attacks. So in the first column, there are 7 triptans. There's 7 triptans. There's DHE, and there's this mitidan. All of them are good, but you would never want to mix them. You never want to take, for the same attack, sumatriptan and rizatriptan. That's too much triptan in your system, and it might not be safe. And then with the nonsteroidals, you really don't want to have naproxen and indomethacin, let's say, in your system taken together. That's too hard on the kidneys and the stomach. That's not safe. But it's perfectly safe to take it with the naproxen with sumatriptan. So this kind of, and you can kind of tailor your acute treatment plan by knowing that some of these combinations are, maybe just right for you. So, don't use 2 things in a column, but you can safely use things from 2 different columns to make a combination that's just right for you. There is, a thing called rebound headache, and it's a real thing. And if you use medicine over and over again, certain abortives over and over again, the migraine disease is going to slowly worsen. And the medicines that are most likely to do that are opioids and butalbital. To a lesser extent, you can get that from triptans and from nonsteroidals. You probably can't get it from the GPANs like Ubrelvy and Nurtec. So, be aware about rebound headache. Set some limits for how often you can use those if you must use them, and avoid rebound headache, or things will inevitably get worse. And then there are other medicines which, if you use them too often, other kinds of trouble develop. So these are not for frequent use, but they're very valuable in managing particularly severe attacks. Oral things like chlorpromazine, another name is Thorazine, nicknamed the hammer of Thor, will, probably put you to sleep. That's a medicine that I might prescribe for somebody who, is just in horrible pain, sick, nauseated, and is in too much pain to fall asleep. It's effective for migraine. The cost is making them very, very sleepy. And sometimes that's a good cost. That's a good thing. And that's chlorpromazine. And I won't go through all of those, but many medicines that are potent and effective can be used that don't go through the stomach, including the compazine suppository, the Phenergan suppository, the DHE injection, the ketorolac or toradol injection, and the ketamine nasal spray. So, just a reminder, for some people, anything you put in your stomach It's a waste of time. It's just going to sit there, or you're going to throw it up. So don't go that way. Go another way. And there are some, some strategies that we use to do that. Now, some people need a bridge strategy to keep them out of the emergency room and to keep them sane and to break the pain cycle. And there are certain medicines that we use as a bridge. Now, let me define a bridge. It's something that you give over a number of days. Typically, it's between 3 and 10 days, and you take it every day. And over that period of time, the severity of the headache comes down, not right away, like in a abortive treatment, like an acute treatment, but over many hours or a few days, the cycle just kind of severe headache just kind of falls apart. So here's an example of a person with chronic migraine, bad chronic migraine, in their calendar. And you can see that they took an acute medicine on day 5 and day 6. Those are the green arrows when the headache spiked up. And then again on day, whatever that is, 18 and 22 and 25 and 33. And then it just got really bad. And day after day, and after 5 days of severe migraine, more than 7 out of 10. I don't know why the scale goes up to 12. Don't ask me about my Excel skills. And then the bridges started, and you can see that over a couple of days, it brings the headache from a 10 to a 2. And that's what a bridge is supposed to do. And we think that there are a number of strategies, and I've given you some that we used as bridges when a person is in really bad shape with an ongoing, persistent, long-lasting migraine attack, and the acute medicine just isn't working. So that's a bridge. I suspect many of you, if not most of you, have needed a bridge now and again. Now, one concept is IV treatment outside of the emergency room. So you may need IV medication because the migraine is that out of control and the impact on your life is that severe. But even then, the ER is still not a great place to go for the reasons I mentioned. Not only are ER doctors, a little bit distracted thinking about, 100 other things going on at the same time, types of diseases, and don't have the expertise that a headache doctor, a neurologist, or, many people have. But they don't have the environment that's appropriate for a person with migraine during a severe migraine attack. So there's inpatient settings and there's infusion centers. And we'll use our infusion center for 1, 2, or 3 days to give medicines to break a bad cycle. And then the inpatient unit is for treatments that need to be given over more than 3 days, 3 or more days, and are more intensive. And you can give more medicine and stronger medicine in a monitored inpatient setting. So the inpatient is for more, you can control it better because the patient's there 24 hours and you can give more medicine, but increase it and adjust it much more often. You can manage potentially serious medication withdrawal if you're taking somebody off habit-forming medicine. If they're, having comorbid psychiatric problems or depression or trouble coping, or you can get a psych consult. You can get other consultations from specialists. And there's an opportunity in an inpatient setting for people to meet, to come together and to educate one another, and for classes to be given. In an infusion center, it's less disruptive, it's less expensive. You get your treatments, once or twice in a day, and then you go home at the end of the day. You need fewer nurses, fewer administrators. You can you can do a good job for most acute severe migraine attacks, and do it in a relatively efficient way. So if you need IV treatment, not necessarily the ER, infusion center or inpatient might be appropriate. And that is my talk. So I'm going to stop sharing. I hope that was a useful way to think about, staying out of the emergency room, how headache doctors kind of think about that problem. I kind of look at, if my patient had to go to the emergency room because they had a migraine attack and it wasn't going well, I think that kind of failed them. I should have been able to give them a plan that kept them from needing to do that, because chances are it was a lousy experience.
Yeah, ERs are fun. Thank you very much. So I have a few questions here for you. That was a great presentation, and I think you explained it really well, so thank you. So I wrote down some questions. How do you stay out of the ER with hemiplegic migraine? Do you have any idea around that?
Yeah, I mean, that's a really kind of a tough question, because if it's hemiplegic migraine, the ER is probably not that great a place to go. And when you get your first attack of hemiplegic migraine, you have to go to the emergency room. It could be something else that needs a neurosurgeon, or needs a clot busting drug, to break up the clot in your brain, or something might be going on. And that's really for everybody when they get their first hemiplegic attack. Probably should be seen in the ER. But hemiplegic migraine is migraine, which means it happens over and over again. And it might be, it's always rational to go there the first time, and possibly rational to go there the second time. But the 10th time, the 50th time, you're going to see a new doctor who doesn't know you, who's worried about the same old lists. Do you have a bleed in your brain? Is there a clot in the blood vessel? Is this some kind of seizure? And, or are you faking it and you need a psychiatrist? And, they're going to have to figure it out for themselves every single time. And it's just really dumb after a couple to be in that. So you need a plan. You might need IV treatment. An infusion center would be a far better place if IVs are absolutely necessary to control a hemiplegic migraine attack.
Yeah. And that's a great point about the ER too, is every time you go, you usually see a different doctor, right?
Yeah.
So
and in fairness to the doctor, they see a person who's paralyzed and looks like they have a stroke, and they're trained from the time they're medical students is that's the CAT scan, and that's and that's a consultation, and that's looking at the carotid artery with an ultrasound or an MRI. You need treatment for migraine, not for stroke.
Right. And how about, do you have any tips on vestibular migraine? Is that somewhat similar?
Yeah, I'd say that that's very similar. I think it's a little bit easier sometimes to, the first attack, maybe half the time, your doctors can be smart enough not to send you to the ER, or there's enough evidence there that you might not have to go for the first attack, but it's the same situation, like, I do want to say, and this applies to vestibular for, brainstem migraine. There is sort of one condition where I really think that there's no choice, and the ER is the right choice, and that's the person who just cannot stop vomiting. They can't take their preventives. They can't keep anything down. They're getting dehydrated, and that's making their migraine worse. And they're retching and vomiting. And like a bag of fluids can do so much good, and a little bit of nausea medicine, if that's all you get, it's worth, that would be one situation where the ER, is it the right place to go, and waiting for a day or two to get into an infusion center, if you're, got this incessant vomiting, is just, that's not right. Go to the ER for that one.
Okay,
I
perfect.
should have said that.
Okay, okay. Someone had a question. Can Aleve cause rebound headache?
Maybe, yeah. I think I think we always think about rebound as, how much of the medicine are you taking? And sometimes it's also that, what is the brain of the person taking that medicine? So I do think that there are some people who do get into rebound from Aleve. I think among all the things that can cause rebound, it's like second from the bottom. At the bottom are Ubrelvy and Nurtec, and they probably don't cause rebound. And Aleve is, maybe in some people it can, but it's really not a bad actor.
Okay.
And then, the worst offenders are the opiates and the barbiturates, the Furoset and the Percocet.
Okay, good to know. So here's a question. There is a participant listening tonight. She said that she takes 100 milligrams of Rebound 1 time in 24 hours. And if it doesn't work, then she's used her sumatriptan injection. Based on your chart, should she not be doing that?
I mean, not, first of all, I'm not her doctor. I can't really say. I'm a little bit concerned about that. There is you could argue that they don't overlap. But I think that most headache specialists would have a little bit of concern for that. I guess let me try to explain. So sumatriptan works on the serotonin 1 receptor, but the subtype B and the subtype D. And Rebound, lasmiditan works on the subtype F of the same receptor. And so does blocking the B, the D, and the F put you at increased risk of some problem from blocking too much serotonin? There's not enough information to know, but some people have a little bit of concern about that.
Okay, so you not being her doctor, you can't say, but maybe bring it up to her doctor.
Yeah, whether they consider that an issue or not. And they may have more experience with that combination than I do, or know something about the combination. Lasmiditan has been on the market, I think, for about a year only. So there hasn't been a huge amount of opportunity to know about that combination.
Okay.
And just, I know this is getting a little bit off track, but when there are new medicines, there are all kinds of new combinations. And, for a while, people are going to be really worried about new combinations that they just don't know, whether something bad could happen. We were concerned, with the monoclonal antibodies like Aimovig and Ajovy, and the oral CGRP medicines like Nurtec and Ubrelvy. Over time, we have become far less concerned, and most of us think that those combinations are now safe.
Okay.
But in the first 6 months or a year, we were very nervous about the combination.
Right. Yeah. You don't know till, yeah. Okay, great. Okay, let me see. Is there a resource to find infusion centers around the country? I know there aren't many, right?
Yeah, no, not that I know of, and that's a great idea. I really wouldn't know how to put it together, but I think that's a brilliant idea. I mean, the trouble is that, in my opinion, somebody isn't a headache specialist until they set up their infusion center and make that available for their patient. But I'm a little biased.
Okay. All right. Yeah, that's a good, I'm gonna write that down. Thank you for asking that question. Rosie, I think did. Thank you, Rosie, for bringing that up. What are the optional medications for outpatient IV?
Outpatient IV?
Yeah.
Or do you, I mean, there are a few places, and a little bit controversial, that'll, send the visiting nurse to your home for, to give, IV steroids or IV Toradol or just a bag of fluids. I don't know of a lot of people who are doing that. And, if something happens and, there's no medical professional around, I do have some concerns.
Yeah.
And then there's what I talked about. There's infusion centers and hospitalizations, and those are much more common. And when we started, we added on to the chemotherapy. It was a little disconcerting for our headache patients that they would go down to the chemotherapy suite, and just a completely different environment. But they needed the treatment, and that was the infusion center we could get for them.
Okay.
Now we have a different one that's a better environment.
Yeah. Well, I've been to both, so I'm picturing both. Okay. So I'm going to ask you one more question. You on here, but we're running over time a little bit. So a few people have asked about chronic migraine. Can you explain chronic migraine a little bit? I guess people are wondering, have you have suggestions for chronic migraine? Can you speak to chronic migraine?
Yeah. Chronic migraine is, a complication of having episodic migraine for most people when they start with their migraine. They get, attacks that aren't every single day, maybe menstrual migraine, maybe weekend headache, maybe, when there's a storm going through and they're headache free the rest of the time. But at some point, when the attacks start to come too close together, the brain itself starts to change, and it becomes, prone to making headache and having symptoms of migraine all the time. So someone who has, maybe 10 migraine days a month might find that even on their best day, they're more sensitive to light. Their scalp is more sensitive to being touched, even when they don't have a headache. And as the disease advances, the headache happens every day. They're never headache free. And, and then some people, actually every single day qualifies as a migraine. They have a sick headache with multiple symptoms, including severe pain, light, sound sensitivity, brain fog, dizziness, et cetera, et cetera. And that happens every single day. Unfortunately, it's not weird. It's just, one when migraine gets really bad, that's what it's like.
Yep, I'm right there with you. So, well, thank you so much for your time, Dr. Young, for answering the questions for us, and we really appreciate it.
Thank you.
Yes. So I am going